So the stuff I'll talk about is just the general clinical practice, but I've kind of arranged it around the chapters of this book because it was also nicely presented. Bariatric Psychology and Psychiatry by Alfonso Troisi, 2002. It's a succinct, very well laid out book that sort of describes all the issues very well. It's in the reference list, but I would be familiar with the published literature on these subjects, but this is just a more up-to-date version, and so I've used a lot of his citations. Now, I get asked to do these privately as well, so there is a general consensus that bariatric surgery candidates should get a psychological assessment. And as you've heard this morning, there's a lot of issues around informed consent that don't happen. And so part of the assessment is making sure that that does happen. And that the patient knows exactly what's ahead of them, not alone just for the procedure, but what is life going to be like afterwards. And can they cope with what's coming down the road? Do they have the skills? So in this service, we assess at the beginning, the initial new patient clinic, and again when they request a referral for surgery, and then the pre-surgery screen, and then again they're reviewed after surgery. So I should say that there's about a good third of patients that need very little psychology input, if any. It's a screen, they're fine, off you go. Don't need to see you again. We do check in just to make sure nothing else has arisen, but a good third have no issues. And I suppose a lot of those are the people that will go abroad and not run into trouble from a psychology point of view. Now, the red flags we're looking for are that the patient expects surgery to do things that are way beyond the scope of surgery, i.e. Make their life better in so many ways that have nothing to do with the weight in the beginning. Or there's psychosis, or there's suicidality, or there's major depressive disorder, or there's basically personality disorder, or there's current binge eating, or there's alcohol or drug misuse, or severe cognitive deficit. I'll go into all these. So a lot of our work is managing people's expectations. And that's weight loss expectations as well as broader than that. So I suppose these are some of the unrealistic goals. Surgery is going to be the answer. Surgery is going to cure unhelpful eating habits. Surgery will address conditions that have nothing to do with their weight. People will be delighted with this brand new body, and they're going to be fit and they're going to be happy. And of course we know there is no magic bullet, but people are desperate. So we do want to explore exactly what they expect. I mean, I've had people come back saying things like, my mother-in-law still hates me. I thought it was the weight. I've had surgery. My husband still won't clean up after himself. What does that have to do with the weight? My boss still treats me badly. Where they blamed everything on the weight and had nothing to do with it. So there are unexpected changes in relationships particularly. And this is within intimate relationships, wider family relationships and friend groups. So something like if one person is the biggest in their friend group, they have surgery and now they're not anymore, what's the knock-on effect? All systems like stability. If you change one thing in a system, it has a knock-on effect, changes everything. So I've had people come back saying there was jealousy, envy, resentment. Somebody could always say, well, at least I'm not that big. And now they are that person because the biggest has had surgery and isn't in that position anymore. insecurity in intimate relationships. I've seen a lot of couples break up that you wouldn't have guessed would break up. Sometimes when the obesity is seen as a disability and the other person has something like, I had a couple where the man had a significant hearing impairment and his partner was living with obesity, and so in his mind that made them equal. So when she started losing weight, he became very insecure, and for him, she had one up on him now. They weren't equals. Those things need to be talked about. Particularly people growing in confidence and assertiveness, and that upsets a relationship. And I have seen, sadly, a lot of couples break up because they didn't anticipate it. How the weight loss would change their relationship. For example, one man would come in from work, he'd be tired, and his wife had him all to herself all evening, and then he had surgery and became more active and was out doing the things that he used to do. She had lost that, and that caused upset. So we really encourage people to talk about how the changes are going to affect the relationship. And then just on the most basic level, shared meals. When your portion is tiny and there's a lot of things you can't eat, eating out can become a bit pointless. And so the most basic way that we connect with people is over a shared meal, and that can change. And sometimes they won't have thought about that, or it'll come as a shock. So the personality traits associated with obesity, and again, this is sort of excluding the roughly third of patients who don't have any of the issues, but then they're the people that we interact with the least. So the ones that we interact with the most have the increased impulsivity. We had one doctoral student do a study on our patients looking at ADHD and found there was far more of it than anybody knew in this patient group. And of course that's the impulsivity and the not planning and poor stress tolerance and things like that. The external locus of control is just thinking that you're at the mercy of the forces around you rather than in control. And then having an insecure or avoidant attachment style meant that food is often the attachment object. So the traits associated with the good outcome: high cooperativeness, persistence, low novelty seeking, low impulsivity, internal locus of control. And I mean, those are your ideal patients, aren't they, for any sphere? So we talk to all patients about the honeymoon period, when just everything, just like any honeymoon, everything's wonderful. Goes on until after the lowest weight is reached and then kind of wears off. And the sad thing is that sometimes that's the opportunity to change a lot of one's habits. But because it's a honeymoon period and nothing bothers you, you may miss that opportunity to really develop other outlets, other interests, other ways of coping. Now, in a 10-year follow-up, there was an increased use of mental health services. So it doesn't have the magic bullet effect on mood and anxiety either that people might assume, and that patients certainly themselves assume. So after 10 years, it's pretty much back to baseline for depression. And even though the medical comorbidities improve, the kind of felt sense of quality of life doesn't improve as much as you would expect. So body image and body dissatisfaction, there's a common occurrence we call the mind-body lag, and that is just when a patient describes knowing that they've lost a lot of weight, but when they look in the mirror they see exactly the same person. So they lift up a garment, so say they're in a size 26, they lift up a size 20 and say this can't possibly fit me, and in fact they're now down to an 18. And they know that objectively, but they just can't feel it and can't... they're not living in that body. So, the gap between two chairs is, I have to go around the long way, I won't fit, and they will. And that can be very disturbing because it feels like they've given up the pleasures of enjoying food that was common to all of us, and they haven't got anything in exchange because they still feel like they're looking at the same person. It can take up to 2 years, and it's perfectly normal. How many, I can't tell you, and what are the predictors, I also can't tell you, and that was not in the literature. Childhood trauma is a big one for us. We give all of our patients a 10-item questionnaire called Adverse Childhood Events Inventory, verbal, physical, sexual abuse, emotional neglect, physical neglect, parental separation, parental mental illness, parental substance abuse, interparental violence, and prison. I think are all of them. So the rates of having a history of adverse childhood events is higher in our population and in the bariatric surgery seeking population internationally, higher than in the general population. So why is that? Well, a number of different things. One is that if you've gone through a very difficult childhood, your dopamine levels are literally lower and you need a more powerful hit, whatever form that comes in. And in our patient's case, it's food. You just need a bigger hit to feel happier. We know that the stress increases your ghrelin, your hunger hormone. And then there's epigenetic changes to the obesity genes. There's alterations in the gut microbiome, and we know that that influences weight significantly. And of course, if you have a rotten childhood, you're more likely to be depressed or have PTSD and use binge eating or emotional eating to cope with these things. And so those are just the factors that play into the link between childhood trauma and weight gain. So what does that mean for clinical management? Well, we do have to have a slightly different, or it's an additional approach to people with trauma history. So the basics of the Fairbairn model will apply to all. Regular meals, eat by the clock, don't allow yourself to get very hungry, have the planned snack. But as well as that, we need to know what was the role of the binge eating and the emotional eating in their emotional management. Why are you doing that? What are you getting out of it? So there's just the active eating is soothing. It's a self-care. It tastes nice, and just the sensation counteracts low mood. But what about eating beyond satiety? Well, it's the food coma. It's the numbing effect. And a lot of patients will tell you that is what they're looking for. They want to feel numb. And then there's the weight itself that protects against unwanted sexual attention, in particular with the people who have a history of childhood sexual abuse. And so many of our patients have a history of really severe bullying in school, and so they're growing up expecting to be rejected and expecting to be badly treated. And the weight kind of can be protective because it preempts that. They'll be rejected before there's a chance to be rejected for who I am. You reject me for my weight, I can kind of live with that, and that's a lesser evil than rejecting me personally, the inside person, if you like. So we will treat childhood trauma, but more often, and because there are so many, we refer them to the National Counselling Service, which is a free HSE-funded service where they'll be seen weekly for as long as necessary. And we'll say that from day one because it just takes so long to sink in. They're absorbing so much new information when they come to our service, but we'll always ask them, are you interested in surgery, just to find out where they're at on that. And that when the trauma history emerges, that needs to be addressed so that we'll have the best outcome from surgery when it comes to that time. So we'll try and word it not, this is a barrier and you can't have surgery until you go and sort your history out. It'll be, we don't want anything to get in the way of a successful and smooth transition from our service to surgery, even though there is the waiting list. And so it's really important that anything that could get in your way or could affect the outcome of your weight loss journey will be addressed, and in particular the childhood trauma, and there's this great service and etc., etc. But it can still take 6 months. It's a self-referral service. We can't refer them. So we'll give them the all the information. People just have great resistance to lifting that lid off that can of worms. It's very unpleasant, and we know that, and we'll support them to do that, but it's something that we have to say over and over again. So eating disorders then. There isn't a consensus in the international literature on binge eating disorder being a clear contraindication, but it is for us. And that's just because the people who go into surgery still binge eating have a much poorer outcome across the board. So the Fairburn model is great when the binge eating is just a product of yo-yo dieting and, you know, the severe restriction, and then you can't maintain that and you kind of bounce back and eat too much, and then you're feeling rotten about that, and, you know, that goes on for years. So in the absence of pre-existing psychopathology or childhood trauma, it works well. It's not enough when it's against a background of childhood trauma. And that's just because of the increased risk of alcohol use disorder, self-harm, and deterioration of mental health after surgery. Now, the literature does say that eating disorder rates increase after bariatric surgery, but I haven't come across much of that in our service. I'm not quite sure why that is. Is it just because we have a much longer lead in, and so we've kind of preempted it by those people not being referred on the same scale as they might be in other countries? So the support groups, you've heard a lot about ICPO, and then the Facebook groups and the ones that our patient advocates are involved in, and they are great. We also provide a service that support group hasn't been as well used as we'd like. They stopped for COVID, they've started again. We do like to get patients to attend who are close to surgery or even, we think, have unrealistic expectations, so that they can meet people who've had surgery 6 months ago, 2 years ago, 5 and 10 years ago, and really see what. And like you've already heard, that people are surprised about the regain, but they do need to know. So depression, there's a kind of circular relationship, because of course depression increases the risk of weight gain, and the weight, living with obesity itself is puts you at higher risk of depression. So talk about being caught in a loop. And there is more depression seen in people looking for bariatric surgery than in the general population, and in weight-matched controls. So it's obvious, I suppose, that the weight bothers them more than it does people who are not depressed. So, of course, the depression affects health behaviours across the board and makes people unhappy about a lot of things, including their own bodies, and more likely to have eating disorders or misuse substances. So some of the things that we do as psychologists, we'll help people understand why they do the things they do more, and help them with coping skills, and keep them plugged into support systems, family, friends, communities, all of that. Self-compassion is a big one because, of course, the internalised stigma is so strong, and dealing with the trauma history. Most of our patients who have a history of depression, anxiety or anything else are well plugged into adult mental health services. We do very little referring to those services, but as I said, a lot to the actually trauma therapy. So anxiety, OCD and PTSD. So many of our patients come in with anxiety. There is far less research on this because I suppose it's not seen as serious as depression, because it's not as connected with suicidality. But it doesn't improve with surgery. So, and we've certainly seen that in our patients, and that's surprising. So mood disorders do improve, although they're back to baseline by 10 years. Anxiety disorders don't tend to improve very much. And then the binge eating and the emotional eating tie in with anxiety just because it's a way of regulating the anxiety. And then, as I said, the sedative effect of being very, very full does actually reduce anxiety. So there was a point I wanted to make on an earlier slide just about the it was on alexithymia, which is just a difficulty reading or understanding one's own emotions and responding to them appropriately. The technical term for that is alexithymia, but there's more of that seen in our patients, and it even goes to the physical level. So misinterpreting, for example, anxiety as hunger. So everyone has said at one point, I can't go to school, or your kids have said it, I can't go to school because I'm sick, I have a really bad stomach ache, I feel sick, I want to vomit, I can't go to school today. And you find out they have a new teacher who's mean, or they're being bullied, or they haven't studied for their test or something, but it's anxiety. But they're interpreting it as sickness. Well, that's what it feels like. But a lot of our patients will interpret that as hunger. So pain in your stomach means you're hungry, but very often it means you're anxious. So even that, figuring out what do the different body sensations mean, but that's just an illustration of how overeating or eating at all can be a kind of a self-medication for anxiety. Now, we don't see a lot of obsessive compulsive disorder here, but when we do, we'll use things like internal family systems therapy, compassion focused therapy, EMDR. Do get a lot of complex PTSD, and that's obviously from childhood trauma rather than adult events like car crashes, though there's a bit of that too. Mostly it's complex PTSD. Now, there's no evidence in the literature that it gets any worse, but we have certainly seen that it does get worse, because when someone has complex PTSD from childhood trauma and they're losing both the protection, the physical protection of the weight, and the ability to self-soothe, their symptoms obviously increase. So I was kind of surprised that that's not reflected in the literature. Personality disorders, again, nobody's born with a personality disorder. It comes out of childhood maltreatment, and we certainly get our fair share in our patient group. So their difficulty coping with the negative emotions, again, impulsive eating or alcohol use, they can be very difficult patients to deal with, because the perceived threat in so many different situations, it's very easy for them to feel victimised, or to feel that the professional people are against them or trying to sabotage them, because they just see what they've experienced in their own childhoods. They'll project that to people they have to deal with. And a lot of our interactions are kind of difficult for patients, as you've heard. So we're not trying to be mean, but it can be picked up that way, and much more so by people with a history of personality disorder. So it's really important that that's identified, and that teams aren't split, and the communication is clear, and nobody's saying anything to a patient that the other team members can't back up, or nobody's promising them anything that the others can't deliver, because they're the patients that will keep you busiest for longest. So this is a big area for us. Particularly alcohol use disorders after surgery. Now, the international literature is all agreed that it does get worse, particularly after the second year. So one of the interesting conundrums is about alcohol is that the lifetime prevalence of alcohol use disorders is higher in a bariatric surgery treatment seeking population, but very low at the time of referral. Now, that's not just because they're trying to that they're playing it down so that it's not seen as a barrier. It really is that as BMI goes up, alcohol intake comes down. Part of that might be, well, I don't know, I just surmise you need to drink quite a lot if there's a lot of you to get a hit. But that changes, and the incidence of alcohol use disorders doubles after surgery, quadruples for drugs. Now, that's an American thing because of the culture of opioid prescription. Thankfully, we don't have that, and I've never seen it here. Doesn't mean it doesn't happen, but it has never come to my attention in 21 years of somebody developing a drug abuse habit after surgery, but lots and lots of alcohol problems. And that's why we're super strict about no binge drinking at all coming up to surgery. And in our patient group, it seemed to be unresolved childhood issues or not having a replacement form of pleasure. So we do talk about hobbies and interests, and thankfully we have an OT to help us now, and a kind of an addiction transfer as well. And I'm running out of time here. Suicide and self-harm, those things increase. They're probably very tied to the alcohol use problems as well, and the unmet expectations and the resurfacing of depression and anxiety after surgery. And the weight regain, and like the patient advocates were talking about, the shame of the regain is worse than having the weight in the first place. Now, that's in the literature. We haven't seen it in our patient population. Doesn't mean it's not there. Intellectual disability then, there was a kind of an assumption that people with intellectual disabilities wouldn't do as well with weight loss. It turns out they do just as well as the main group. And we have done weight loss surgery on people, but not with severe intellectual disability. They would have been mild or moderate, and they would have had a lot of family support. There's very little research on this, except among people with Prader-Willi syndrome, and we would never do surgery on anyone with Prader-Willi syndrome. Absolutely no point. And that's what the studies also concluded. But the one we would do for people with mild or moderate intellectual disability would be a sleeve rather than a bypass, just to avoid some of the malnutrition problems. And of course, we know that psychiatric disorders are more common in people with intellectual disabilities than in the general population, but not binge eating disorder, interestingly. So who is suitable for cross-border directive bariatric surgery? Ideally nobody, but like I said, that third of people who, from my point of view, this is now not the medical point of view, just the psychology and behavioural point of view would be the people who didn't need to see a psychologist in the first place. They're the ones that'll go and come back and live happily ever after. So that's it. Thank you very much. Do you want to take questions now, or? I don't know if that's a good thing or a bad thing.
The National Counselling Service, is that only for people with mental cards?
No. It's HSE funded, free service for everybody. Yeah. Yeah, it's very good service. It's nationwide. Now, they might be waiting for about 6 months for an appointment, but once they're in, they stay in, and they're weekly sessions. They'll sometimes kind of farm it out to private practices, and they're often more flexible in terms of time. They'll offer evening appointments.
Mine is more of an unfortunate waiting list question. I know for myself, I'm in primary care, and the psychology waiting list is about 2 to 3 years. So do you have any advice in the meantime for, while they're on the waiting list, what might be helpful?
Well, the patient, the ICPO, are you talking about our patients or
Post-bariatric surgery?
Post-bariatric surgery, the ICPO and the National Counselling Service is about 6 months. Some that identify as addicts, the Overeaters Anonymous. I suggest that to a lot of people that describe themselves as food addicts, but very few people actually go. But it's very successful for alcoholism and drug addiction. So, yeah.
Just in relation, I suppose, to post-COVID over the next number of years, like, are you seeing anything, the impact of COVID on any psychological impacts on patients?
Well, they'd be more anxious, people who are anxious about their health, about knowing that they're in a higher risk group. I suppose it's similar. It's interesting, some of them commented, now you know how we live our lives all the time in isolation.
Post-surgery, if somebody does reveal that they have increased alcohol intake and you can tell that they're developing or have gotten a dependence on alcohol, you know, what the best steps to take to support them as a dietitian?
Just to refer them on to an addiction service, make sure the GP is aware. They would have fairly good access to adult mental health services, even though, like the psychology and primary care, there's long waiting lists, but for the general adult mental health service, there wouldn't be a long waiting list. And just so that they are really made aware that it's a serious problem and needs action. And of course, Alcoholics Anonymous.